So my talk is the last one between you and the door and our question and answer session. But I think that this is a talk that has affected every single person across the globe. IBD patient, non-IBD patient. This is something that has turned our worlds upside down over the last 2 years. And either we want to know the updates and we want to stay on top of it, or I have some patients that I see in clinic that are sick of it and they don't want to hear any more about this. They're over it. I think we all are to some degree. But what I'm hoping to provide today is a little bit more of an overview of where we are now with COVID-19, some of the updates in terms of the literature that we've been able to garner over the last couple of years, and how it specifically affects IBD patients, particularly patients that are on therapy, immunosuppressive therapy, as well as we'll touch on vaccinations and some of the new recommendations that have been out. So, as a brief overview, as we all know, coronavirus, these are human and animal viruses. They've been detected since the 60s. They've been around for decades. But in late 2019, this new coronavirus was identified in China. And in February of 2020, the World Health Organization designated this as a disease called COVID-19, which is a coronavirus disease 2019. Now, the virus that causes COVID the virus's name is SARS-CoV-2, right? And this is severe acute respiratory syndrome coronavirus 2. And there's a distinction here between the virus and the disease caused by the virus. So this virus goes around, not necessarily everybody develops the symptoms of COVID-19 or the virus, the disease itself. It's variable in who may present or who may not, but there's a distinction there. And this is a schematic that I got from the Johns Hopkins University. Johns Hopkins University has actually been wonderful about updates regularly on COVID-19 in terms of incidence, death rates, all sorts of different trends. But what we see here, particularly on the green line, is the US trends, essentially from the beginning from 2020 up to last week, essentially. And what we see here, there have been a few spikes associated with this. Sorry, you can't see my cursor here, but you've got one spike kind of between October 2020, late 2020, and essentially that coincides with the Delta variant that we saw. That evolved, or was first detected in India. We found that it was more transmissible than the Alpha variant. It caused a bit more of a severe disease as well. And then in late 2021, or at least after the Delta variant, things got better. Our numbers started to trend down, and then in late November this last year, we saw the Omicron variant evolve. And essentially, these variants are mutations of the protein, of the viral protein itself. Specifically with Omicron, it's a mutation on the spike protein. And it was found to have increased transmissibility. There was a decreased susceptibility to neutralizing antibodies. And we saw quite a significant spike at the end of the year and the beginning of this year. And essentially, what we've also seen, which has been a really good thing, is that as much as we had a sharp rise in this variant, we also have seen a sharp decrease in this variant. And kind of now we are here today where our numbers seem to be a lot better across our communities. However, there is another variant now on the rise that we need to be aware of. But where are we right now? I can say that most hospitalized patients, we do see patients still in the hospital, but most of them tend to be unvaccinated, not boosted, or immunocompromised to some degree. And our therapeutic options have improved over the last couple of years. We do now have oral antiviral medications. We also have something called monoclonal antibodies. So we have developed some algorithms in the treatments for COVID-19 in the more severe cases. But what we are seeing more recently over the last several weeks is that there's another variant on the rise called the BA.2 variant. From what we know, it doesn't seem to be more severe, but we do not know if it's more contagious at this stage. And what we're going to really need to see are the trends of where things are going. And we tend to lag behind Europe a few weeks, but from what we do see right now is that it is more of, it's more prevalent right now in Asia. They're seeing up to 1,500 cases a day in Shanghai. They had recently closed Disney Shanghai. So with this variant involving, what we're going to need to be is essentially flexible. Our masking policies over the last few weeks have changed, and it's been a good thing. We've moved in the right direction, but things may change as we see what these variants do and how it affects us on a day-to-day. Essentially, we need to remain cautiously optimistic. Now, in terms of the transmission, we've talked about this, and I've talked about this with many patients. There's 3 essential ways where COVID can get transmitted. We talk about what we call fomites. Essentially, this is where the virus stays on contaminated objects or surfaces, and it can be transmitted through your hands, eyes, nose, or the mouth. And usually, and this is where we say frequent hand washings, hand sanitizers can be helpful. The other common way is droplets, right? This is the moist particles that are expelled from speaking, singing, breathing, coughing, sneezing. And this can spread either through the eyes, the nose, the mouth. They usually don't remain airborne very long, and this is where that 6 feet of distance, masking tends to help. Excuse me. And then the other way is aerosolized. And these are tiny particulates that can be carried through shouting, singing, speaking. Usually this is seen or can be transmitted in areas where ventilation is poor, closed spaces. Now, masking, we do find that when it's worn properly, it can be effective in preventing any transmission. And then when we look at the incubation period for COVID, it's usually about 3 to 5 days after exposure, but what we have found is with the Omicron variant, that incubation appears to be shorter. And what we see as well is during that infectious period, that's the time when patients usually will get tested, or we may want to get tested for it. And there are 2 types of tests that are very commonly used, what we call the rapid test as well as the PCR. And in that infectious period, what we can see here in this graph is that that positive rapid test has a bit of more of a shorter period where it can stay positive, or it can detect the positivity, versus a PCR where it can go up to 10, 11 days even after the infectious period, where that test can remain positive. Now, the clinical presentation for COVID is variable. Somebody that, and at some point, many of us here in the room may have gotten it, or we know somebody that's gotten this condition, and the symptoms are so vastly variable, it's so hard to predict who's going to get what. Most patients can present with a fever. Some can present with difficulty breathing, a loss of taste or smell, muscle aches, pains, GI COVID, so COVID can exist in the GI system. It can be spread that way. Nausea, diarrhea, vomiting. This could be seen, some studies are telling us, between 10 to 50%. Chills, coughing, a runny nose, congestion, sore throat, headaches, and fatigue. Now, I find this pretty interesting, but essentially, this is a diagram where it shows the kind of symptoms people can have and what overlaps, right? So the large orange circle here represents what we call anosmia, a loss of smell or taste. And you see some patients or some people who may develop this may not necessarily have symptoms of diarrhea, cough, shortness of breath. Some people can overlap with all of it, some just may not. And that's what makes this pretty difficult, because you just can't pinpoint exactly what that universal symptom is to say this is what's going on. Everybody has a very different course. And the spectrum is also vast. We can see up to 81% can have mild to no symptoms. Up to 14% can have a more severe course with shortness of breath or hypoxia, which is decreased oxygen levels. Thromboembolic events like pulmonary embolism or DVT, cardiac injury, kidney injuries, what we call kind of the cytokine storm. These are patients that ended up getting hospitalized in the ICU. And then there's this other condition that we're starting to learn about from COVID called long COVID. And this could be seen somewhere between 10 to 30% of COVID patients. This is where symptoms could last over a couple of months. And what we find is that it's independent of the severity of infection. There's an unclear cause of why we have this, who develops this. And what we may think it could be related to the immune system and overactivity in the immune system. Some postulate it could even be a separate disease entity. What we do know is that vaccination does protect against this, and patients are likely to develop that long COVID, somewhere between 30 to 50%. So vaccination can help to prevent symptoms of long COVID. Now, there are two ways which we test here in this country. The PCR test is one of the more common ones that we can use. It's where we have the swab in the nasopharyngeal or the saliva. The sensitivity and the specificity of this test are high. This is probably one of the best tests that we can get. But performance can vary based on the assay that's used, the specimen quality, as well as duration of illness. If somebody is presenting early on or too late in that course, in that spectrum, you may develop a false negative test. The antigen test is actually what we commonly see. Those are what's available through the home kits, or if you travel abroad and you need to get a negative test to come back in the country, this is the cheaper option. And they're less sensitive than the PCR test, and they also are performed with the nasopharyngeal or the nasal swabs. Now, serologies I get asked about often, and this is the immunoglobulin response, the IgG. And it may reflect a prior exposure to the virus, but it's not used, or it cannot be used, to diagnose current infection. And the sensitivity and the specificities of this are variable. And the reason why, there are multiple kinds of coronaviruses out there. So it may not be COVID-19, but it may be another coronavirus that is why somebody may have a positive immunoglobulin. So you have to be careful with the serology testing. Now, therapies are available, and treatment does depend on vaccination status as well as risk for progression. And there are categories of patients who have an increased risk of progression, people who may have underlying malignancies, people who are immunosuppressed. And we'll talk about immunosuppression later on here in the talk. But the treatment options that have evolved, that are now more widely available, include medications like Paxlovid. There's another Sotrovimab, which is a monoclonal antibody that's designed more to be against the Omicron variant, Remdesivir. Early on in COVID's course, there was a lot of information out there about things like hydroxychloroquine, ivermectin. At this point, based on clinical studies, we don't have anything that shows it is effective. And I know there's a lot of information out there, but this is really based and weighed on the quality of studies and looking at things from a balanced way. And right now, we don't have any recommendations for its place in treatment. Now, what does this all mean for IBD patients? Now, this slide is a diagram of what's happening in a normal GI immune system. And there's a lot going on here. Now, in IBD, what we know is this is an autoimmune condition of the GI system. Your immune system is recognizing your GI tract as a foreign invader, and it's attacking it to some degree. And as a result, what IBD is, it's a condition of an overactive immune system. So amplify this times 2, times 3, times 4. And that's what's happening in IBD. And the way we treat IBD, Crohn's, ulcerative colitis, we could treat it with anti-inflammatory medications, but in those more severe cases, we have to use immune suppressive therapy, medications that are blocking your immune system from attacking it. And when it does that, it cools down the immune system to allow your body, your GI system, to heal, which is a rejuvenable organ in the body. Now, with COVID, there's been concern about drug interactions, worsening COVID because you may have IBD, increased susceptibility to the infection, and interaction with all sorts of the medications. What we've learned over the last couple of years is that IBD patients are not any higher at risk for contracting COVID or developing severe COVID at all. So the risk of developing COVID in IBD is similar to the general population. We do know, though, that patients who may be on corticosteroids would have potentially an increased risk for more severe related COVID. And other risk factors for severe COVID in IBD, active disease, comorbidities, and an older age. But ultimately, what we've all recommended across the board is to continue IBD medications throughout, because the healthiest version of yourself is the one where you are in remission, where somebody's GI system is healed. That is when your immune system is working the best to combat any COVID or any other virus that may arise. Now, how do we know this? How did this all start out? So we have, since the beginning of the pandemic, there was something called the Secure Ibd Registry. This is a database. This is an international database that was developed, primarily out of UNC, but it was an international-based database, and there's 2 years of data collection of about over 7,000 patients with IBD. Excuse me. And we've been able to, there's 17 publications associated with this. And what we've learned is we've learned from this database of IBD patients who have developed COVID, who is at higher risk, kind of what are the medications all about. And what we found is that older patients over the age of 60 or patients who have multiple comorbidities, they may be at a higher risk of what we call severe COVID. Severe COVID meaning patients requiring hospitalization, ICU level care, intubation, or death. Now, when it comes to medications, which is one of the million-dollar questions that we've asked from the beginning, what we have found is that chronic steroid use does increase the risk of severe COVID. Chronic steroid use meaning more than 20 milligrams of prednisone for a long period of time, months to years. Years ago, that used to be one of the mainstays of how we treated IBD. But there's been an evolution in medicine and in IBD care where we really moved away from that. But occasionally I do see patients who are still on long use of prednisone or these steroids because it helps them. But this is where now we really need to keep a close eye and try the best we can to wean off steroids. If you need it for short periods of time, that's different. This is more in terms of the long-term effects of steroids. Now, what we have found is that there are no statistically significant associations between mesalamine or sulfasalazine and adverse COVID-19 outcomes as well. Initially, when the database came out, we had some concerns about this, but this changed. Biologics are associated with a decreased odds of COVID-19 related hospitalizations. So we find that actually there may be some protection in patients who may be on anti-TNF therapy, interleukin, which is Stelara, or even vedolizumab or Entyvio. Now, late last year, there was a large analysis that was done, over 6,000 patients, where we took patients from the IBD community through the Secure Ibd database, a Global Rheumatology Alliance database, patients who have rheumatoid arthritis, who also use these biologic medications, as well as psoriasis. And what we found from this study, and this was published in a journal called JAMA, that factors associated with hospitalization or death with COVID-19 include older age with comorbidities. We found that TNF inhibitor monotherapy, so patients that could either be on things like Remicade or Humira or Cimzia, they were associated with a lower risk of severe COVID-19, including hospitalization or death. Now, we did find a higher risk of hospitalization in patients who were on a combination of therapies, where there are some patients that in IBD where we need to treat them with a biologic and something called immunomodulator like 6-MP or azathioprine. And we did find that in this study, there was a signal to show a higher risk of a more severe COVID outcome. What we did find, though, is that there was a combination with methotrexate. There was not an increased risk, and it was similar to somebody that was on the monotherapy of the Humira or Cimzia, the biologic alone. Now, in the Secure Ibd database, what we found was a similar result, that patients who were on the combination with 6-MP or azathioprine, they did have a higher risk of adverse COVID-19 events compared with somebody who was on the biologic alone. And here, this graph shows kind of the difference if somebody was on monotherapy with something like Humira or infliximab or Cimzia versus thiopurine monotherapy, which is somebody who was on 6-MP or azathioprine, so 2.2 versus 9.2%, or combination therapy, which was at 8.8%. So what we think is the signal may be somewhere with that thiopurine itself, the 6-MP or the azathioprine. And that's not used very often these days. We do use it in very select situations. And we use it it's a very calculated decision whenever we use combination therapy. And we still have to weigh the pros and the cons of using it. What I can tell you is that in these studies, we did not account, or there were no signals for the vaccinated. So, we don't stop using these combinations if we need them, because ultimately the goal here is remission, because in remission you have the best immune function to combat any illness. Now, when it comes to other medications, we did not see any association with more severe related COVID. That includes vedolizumab or Entyvio, tofacitinib, or Stelara. Tofacitinib is Xeljanz. And this is a schematic or a graph here of the medications that we currently have available in the treatment for IBD, to include things like 5-ASAs, budesonide, prednisone, thiopurines, the biologics. And what we see here is that really there's not much of an increased risk of COVID-19 except for the prednisone. And the risk for severe COVID-19, we know that prednisone as well does that. It's unclear on the thiopurines. Based on some of the data we have, it's suggestive, but we still need more information on this, as well as combination. Now, would you or should you stop your medications to prevent an infection? Essentially, no, across the board. For prednisone, you want to taper it. And then if you develop COVID, if you have a positive test, should you stop the medication? And the answer here is, with the consultation of your gastroenterologist, yes, apart from 5-ASAs like mesalamine and questionable for budesonide. Now, what if you get COVID? You want to talk to your doctor about stopping the medications. Typically, your immunosuppressive medications or biologics should be held during an infection for at least 10 days or at least 72 hours after resolution. But you can continue things like aminosalicylates or your 5-ASA medications, mesalamine, things like Canasa, valsalicide, sulfasalazine, those are okay. Now, we've evolved in our societies as a gastroenterologist. This is a schematic of our algorithm in how we treat COVID-19 in IBD patients. So what tells you, it goes to show, it's a very complex slide, but the point of me showing this is because it goes to show how much data and how much information has been developed over the last couple of years. We really thought through this, where it's been incorporated how to manage things from a guideline perspective amongst gastroenterologists or GI providers. Now, are vaccines effective in IBD patients? This is the other question that has come up. And essentially what the answer here is, majority of patients are able to mount an immune response. We have several studies that have been published called the Corral Hercules study, the Prevent COVID studies. They show an effectiveness. Vaccines are proven safe. There's no associated flares with it. Initial studies suggest an equivalent efficacy to the general population. Over 5 billion people have received at least one vaccine, 2/3 of the world's population. A fourth of the people in our country are not vaccinated, and half are eligible for a third dose. If they're eligible, they haven't received it. We do know vaccines prevent against severe disease, hospitalization, and death. They don't protect as well against symptomatic disease with some variants, but that's not the point. The goal of a vaccination essentially is to prevent severe disease. We initially felt maybe it was to prevent the infection, but that's not a reasonable thing. You're going to still get it, potentially, but as long as it doesn't create the severe symptoms, that's what's most important. A recent study by the CDC showed that during the Omicron surge, the vaccine effectiveness against intubation, death, was 80% after 2 doses and 94% protective after 3 doses. Now, here is a schematic of the current guidelines for vaccinations. And I know this is a pretty busy slide, and this was, I got this from the CDC, but essentially, we are now in primary series for the Moderna vaccine, the Pfizer vaccine, 2 doses, and then that's separated by another booster as well that can be done afterwards. Now, this week, the CDC has also recommended a second booster that is also or can be available, and that's typically, it's been now released for patients over the age of 50 or patients who are immunocompromised. Now, for patients who are moderately to severely immunocompromised, this is a different category. And this doesn't necessarily apply to the IBD population, even the IBD population on immunosuppressive therapy. This is more designed for patients who are transplant patients, who are severely immunocompromised, who require medications to prevent rejection from certain transplants. And that's where a third dose is essentially recommended. A third dose is different than the booster dose because the dose itself is different. So as I mentioned, a second COVID booster has been now authorized or recommended, and this is for adults over the age of 50. And then they also amended this to include people over the age of 12 who are immunocompromised. Now, they did not define what immunocompromised is, but what we can say is that we know IBD patients do maintain a sustained antibody response. So technically, can an IBD patient on immunosuppressives get a booster, another booster right now? The answer is yes, they can. So in terms of future developments, we don't know yet what the crystal ball is going to lie for us. We don't know, there's not been any recommendations for things like an annual booster, even though we're talking about it. Next week, there's an FDA meeting to discuss the COVID booster strategy in this country. Things are on the horizons include intranasal vaccines, which is not yet available in this country. I can tell you at least what other countries are doing. Israel is offering a 4th dose, a fourth full dose. England is offering the second booster. Again, that was something approved in this country. They also approved it. El Salvador in Central America offers a 4th dose for all people over the age of 12. So everybody's doing something a little different here, right? But, essentially what I think lies in the future for us is based on what we see in our data. And as things come in, we had a lot of information that comes in on a regular basis. And it's a matter of really siphoning that information to figure out what's going to work for our population in our country. And the FDA and the CDC have been working hard in trying to go through that data, making sure that things are selected out appropriately that affects the general population. So in conclusion, we know that IBD patients are not at increased risk for COVID compared with the general population. But with the exception of steroids, medications that treat IBD are not associated with a clear harm in the setting of COVID. So please remain on your medications. Vaccination is safe and effective. There's a 3-part series for everyone, and the new boosters were announced this past week. We do have to expect things will change as this is an evolving landscape, and regular communication with your GI team is important in considering medication changes. And that's all I have. I'd like to thank you all for your time.